Hi, my name is Dr. Vas, and today we're going to discuss acarbose-induced hypoglycemia. But before going towards the discussion, there is something you need to understand that acarbose alpha glucosidase inhibitor. It's an enzyme present in human GIT for the absorption and metabolism of the glucose and other glucose entities. Acarbose rarely causes hypoglycemia, but the risk increases if the patient is using insulin or sulfonylureas with it. If you find a patient or you diagnosed a patient with this kind of symptoms or entities, dextrose plus glucose, not sugar or sucrose, should be given to the patient. Acarbose inhibit alpha glucosidase enzyme and delay the carbohydrate and digestion. That is the main functioning of acarbose. This blunt post-meal glucose rise rather than directly increasing the insulin. That is the important part. Disease condition description. Low blood glucose event occurring patient using acarbose because the enzyme is getting inhibited. Acarbose monotherapy is less uncommon in patient with type 2 diabetes. Most cases occur when acarbose is combined with insulin, sulfonylurea, or other oral hypoglycemic agents. The event might be confusing for the doctors because hypoglycemic symptoms are different in different patients. Acarbose alone, if the patient is using acarbose alone, low risk of hypoglycemia is there, but with insulin and sulfonylurea and other hypoglycemic agents, the risk getting increases. Mechanism, as I told you, acarbose inhibits intestinal alpha glucosidase, decrease the carbon breakdown or carbohydrate breakdown, delay conversion of starch, glucose, and other glucose entities, less post-meal glucose rise, lower glucose absorption. That's why the patient who use the acarbose or alpha glucosidase inhibitor uh, showed diarrheal condition more often than other patients using sulfonylureas and other drugs, hypoglycemic agents. Other drugs like metformin and other drugs might lower the glucose. Insulin or sulfonylurea can push glucose to the lower side. Hypoglycemic symptoms might be different in different patients, as I told you. Sweating, tremor, hunger, confusion, these are the common, but most rare symptoms are uh, the patient become unaware of the environment in which he or she is in. That is the main problem with the hypoglycemia. Why sugar is less useful? Acarbose blocks sucrose breakdown. That's why glucose dextrose is preferred for rapid correction of the hypoglycemic fits or hypoglycemic condition. Risk factor and insulin is a risk factor with acarbose use. Sulfonylurea, missed meals, exercise if the patient is doing the exercise for lowering his or her glucose level and using acarbose with it, there might be a problem of hypoglycemia. Alcohol or any other illness that impair the glucose production may contribute to more hypoglycemic conditions. Renal or liver issues. If the patient have uh, CKD or proteinuria and he is or she is using acarbose, there might be a more risk of uh, hypoglycemia. Diagnosis symptom sweating, tremor, palpitation, hunger, headache, dizziness, blurred vision, weakness, confusion, behavioral changes, seizures, or loss of consciousness in severe cases. Check capillary glucose, review medicine and timing, identify trigger the condition, meal, exercise, or alcohol, document response to glucose. Treatment and management. Mild to moderate, if the patient have the mild to moderate risk of or episodes of hypoglycemia, give oral glucose, dextrose tablet, gel, glucose containing drinks. Avoid relying on sucrose, table sugar. Recheck glucose after 15 minutes and repeat glucose if it's still low. Longer acting carbohydrates or like complex carbohydrates might be useful. If the patient have these having these severe episodes, uh, if he or she become unconscious, or there is a problem of swallowing, urgent medical care should be there. IV dextrose when available. Glucagon may be used in selected situation. Review diabetes regime to prevent recurrence of the hypoglycemic fits. Prognosis and prevention. Generally good when hypoglycemia is recognized. Most episodes are preventable by adjusting co-therapy and meal planning. Severe or recurrent episodes require medication review and patient education. Prevention checklist. Take acarbose with first bite of your meal. Do not skip meal. Carry glucose or dextrose tablet with you. Monitor glucose more oftenly if you are taking it with insulin and sulfonylurea. Educate patient to that table sugar may be less effective. That is the clinical summary. If you are using the acarbose alone, rare uh, episode of hypoglycemia might occur. But if you are using insulin, sulfonylurea, or any other hypoglycemic agent, the occurrence or the episode of hypoglycemia or risk may raise. Mechanism delayed carbohydrate digestion plus glucose lowering prodrugs. Treatment use glucose, dextrose, not sucrose. Prevention, meal timing, monitoring, and patient education must be there. Thank you for your time.